Mauricio Sainz BARRIGA. I am an hepatobiliary and liver transplant surgeon in the University of Leuven in Belgium. I have been invited to talk in this congress regarding machine perfusion of liver transplantation. This is a really hot topic nowadays because we are confronted more and more with the shortage of organs. This means that we are transplanting sick, very sick patients, always more and more sick, because there is competitivity between patients, and the sickest gets priority. And at the same time, the quality of the donor pool is remained stable. So we are going to the extremes, trying to confront this shortage. And in the lower side of the spectrum, we have extended criteria grafts, which are grafts with fat, steatosis, more than 30%, or really old donors, or donation after cardiac death, which is a graft that has suffered ischemia prior to the process of perfusion. And in this context, we have to take in account also that from the donor, through the procurement, management of the donor, the procurement team, the experience of the team, the surgical technique, the times of extraction of the organ, the perfusion time when the liver is maintained under ice and transported to the recipient's hospital. In all these steps, there are happening events at the cellular level of the liver, which at the moment of reperfusion, may represent an important ischemia reperfusion injury that may hamper the results of transplantation. So we are trying to do our best efforts to try to solve this problem. We are shortening as much as possible the ischemic times. We are trying to do a match between bad quality donor, good quality recipient, but we cannot always choose, as I said. So it has come a new technology, which is not really new because it's more than 100 years ago that was described for the first time, but it's coming back again in the search for new alternatives. We have had really good results with experience in the kidney transplantation, with randomized controlled trials that prove efficacy of this new method. And now we're trying to apply it in the liver setting. Which kind of perfusion? This means that we're going to take an organ, we're going to place it in a machine, and we're going to perfuse it. That means that we are going to substitute what is happening in the body. We're going to maintain a perfusion of this organ until it gets to the hospital. This is called machine perfusion. This is normally can be one vessel only through the portal. That can be two vessels, to the portal to the artery. That can be, most cases, pressure controlled. It can also be flow controlled. And we have then a choice regarding the temperature at which we are going to perform this technique. Cold temperature means lower metabolism, lower demand of nutrients from the cells of the liver. Higher temperature is a higher demand. So this means that we're going to have hypothermic machine perfusion, we're going to have subnormothermic machine perfusion, we're going to have normothermic machine perfusion. We can also apply, as I said, continuously from the donor hospital to the recipient hospital. And this can also be applied after a period of cold ischemia, just prior to the implantation. This has advantages and disadvantages of them. Nowadays we are working in trying to better define. What it has been proven is that oxygen is important to recharge the cells and to avoid further damage to the liver. We have shown that some grafts that were considered suboptimal may be used after being discarded, and after getting a treatment thanks to the machine perfusion, they may get back in shape good enough to be transplanted. We know that we can prolong the ischemic times, and we know that we can improve the logistics. Of course, this comes to a price, which means a lot of manpower, because it requires a specific trained and knowledgeable surgical specialization. You need also a perfusionist that is going to help through the procedure, and you need to have a space where this machine perfusion is going to take place, both in the donor hospital and in the recipient hospital. So It is now still in a phase of pilot results. We have this evidence, but we don't know yet what would be the best, warm or cold. Cold seems to improve energy. Warm seems to provide information regarding quality of the liver. Is this liver going to work? So now we have some markers that we think are reassuring to use a graph that otherwise would not have been used. But the correct type of marker, the right values that has to be used is something that we are still defining. And in this Congress we have shown the different types of perfusion, the actual results, a little bit of insight of what may come. We are waiting next year. We will have finally the first results of randomized trials that have been running for the last 3 years. And we have a lot of hope that this perfusion, hypothermic oxygenated perfusion or normothermic perfusion, will help us to increase the number of donors available for transplantation without paying a price in the results. Thank you very much.